How is it possible that two patients can undergo the exact same cataract surgery performed by the very same surgeon on the identical day and walk away with completely different vision outcomes for the rest of their lives? One person leaves the clinic thrilled, while the other spends the next 20 years quietly disappointed. The difference doesn't come down to the surgeon's steady hands, the high-tech laser equipment, or the hospital's glowing 5-star online reviews. Instead, it all traces back to a short consultation that took place weeks before either patient ever set foot in the operating room. A quick conversation that most people barely even remember having. Here is the honest truth that very few providers explain up front. The highest risk part of cataract treatment isn't the surgical procedure itself. In reality, cataract removal is one of the safest, most refined, and most consistently successful operations in modern medicine. The real defining risk comes down to a single choice you make while sitting in an exam chair, often in under 2 minutes, and far too often without fully grasping what you're agreeing to. Once that decision is locked in, it is permanent. There is no return policy, and there is no simple swap a year later if you change your mind. You will live with that single choice every waking second for the rest of your life. Every sunrise you watch, every highway sign you read while driving, every face across the dinner table, and every phone screen you look at late at night. The vast majority of patients get this choice wrong. Not because they are careless, but because nobody told them they were making a life-altering decision in the first place. Hello, I'm Dr. Eduardo Perez Alba. Over decades of clinical practice, I have sat across from thousands of patients in that exact exam chair, and I have seen the same heartbreaking pattern unfold over and over again. Patients spend weeks researching local surgeons, scrolling through online reviews, asking friends for recommendations, and stressing endlessly over the surgical procedure itself. A 10-minute operation they will barely feel while comfortably sedated. Then, they show up to their consultation completely unprepared for the single most important decision of their entire treatment journey. The choice that dictates exactly how they will see the world for the rest of their lives. They allow this vital decision to get settled in a rushed conversation they don't know how to navigate. Some patients get steered toward expensive premium lenses that clash with their natural eye anatomy, while others never even learn about the full range of lens options available to them. In both cases, they discover their regret far too late. In this video, I am going to break down exactly what this crucial decision involves, explain why its impact is so massive, and give you a clear framework that separates patients who walk away delighted from those who spend years wishing they could undo their lens selection. I will walk you through the 3 primary categories of artificial lenses, uncover the hidden optical compromises built into each type, and expose the nighttime driving trap that catches so many patients who choose premium lenses for the wrong reasons. I will also explain how common underlying eye conditions can automatically rule out certain lens models, a vital clinical detail that many surgeons fail to highlight. Furthermore, I'll cover the practical monovision strategy and show you a simple pre-surgery test you can do at home to see if it works for you. Eyes, along with the exact questions you must ask your surgeon so you enter your consultation fully informed rather than being sold a lens that isn't right for you. Before we jump into the details, I have a quick favor to ask. Viewers regularly tell me they watch my educational videos but haven't subscribed yet. Could you take 2 seconds to click that subscribe button right now? Subscribing costs nothing, and it genuinely helps this channel share clear, unbiased medical guidance with more people who need these facts before making permanent healthcare choices. Thank you so much. Now, let's start by understanding how your eye actually works, because grasping this basic anatomy makes the entire lens decision crystal clear. Think of your eye's natural lens like the glass lens inside a digital camera. It sits directly behind your colored iris, and its job is to bend incoming light so it focuses sharply onto the retina at the back of your eye, creating crisp vision. When you are young, that natural lens is completely clear and flexible. But as the decades pass, the proteins inside the lens gradually clump together, causing it to become cloudy, stiff, and yellowed, much like looking through a foggy, stained window. That cloudiness is what we call a cataract. Colors lose their natural vibrancy, Oncoming headlights flare into blinding halos at night. Small text becomes difficult to read, and the world dims so gradually that many people don't realize how much vision they've lost until surgery clears it away. Cataract surgery resolves this problem through a remarkably sophisticated, minimally invasive technique. Your eye surgeon creates a tiny micro-incision on the surface of the eye, gently breaks up and removes the cloudy natural lens, and replaces it with a brand new artificial implant in the exact same spot. This artificial implant is known as an intraocular lens, or IOL. It is a tiny, crystal-clear disc smaller than your pinky fingernail, and it remains permanently inside your eye for the rest of your life. This brings us to the core lesson of this video, and I want you to really take this in. The natural lens you were born with could shift focus automatically, flexing seamlessly so you could look at a distant mountain and immediately glance down at a book without missing a beat. Most artificial replacement lenses cannot do that. They have a fixed focal power that is permanently locked in during surgery. So when you choose your intraocular lens, you aren't just picking a piece of medical plastic. You are permanently deciding which distances your eyes will see clearly on their own, and which distances will require corrective glasses. This is the life-changing decision we are talking about, and you only get to make it once. Let's break down the 3 primary lens categories, along with the trade-offs that catch most patients completely off guard. The first category is monofocal lenses. These are the reliable, standard workhorses used in cataract surgeries worldwide. The prefix mono means single, which perfectly describes how they function. They provide one crisp, dedicated focal distance. In the vast majority of cases, surgeons set monofocal lenses for clear distance vision. After surgery, you will be able to see highways, television screens, faces across the room, and outdoor scenery with sharp clarity without glasses. The predictable trade-off is straightforward. You will need simple reading glasses for close-up tasks like reading books, checking menus, looking at your smartphone, or threading a needle. Monofocal lenses deliver exceptional visual clarity with virtually no glare or halos, and they are fully covered by standard Medicare and insurance in most regions. The deal is simple: excellent distance vision paired with inexpensive drugstore reading glasses for close work. The second lens category is where most patient dissatisfaction begins: multifocal and trifocal premium lenses. These are the advanced implants featured in glossy clinic brochures, marketed with an incredibly alluring promise. They have multiple focal rings built directly into the lens, splitting incoming light to provide distance, intermediate, and near vision simultaneously. The sales pitch promises complete freedom from glasses, allowing you to read your phone, drive your car, and work on a computer without ever reaching for spectacles. For many patients, that promise comes true, but marketing brochures rarely emphasize the built-in optical compromises. Because these lenses split light across several focal points, rather than directing all light into a single sharp image, your brain has to process overlapping visual layers. This causes 2 major side effects. First, overall visual contrast softens, meaning edges between light and dark look less crisp, especially in dim lighting. Second, and far more frustrating for many, artificial lights at night can create intense halos, glare, and starbursts around headlights and street lamps. While some brains adapt over several months, for a notable group of patients, those visual disturbances never fully go away. On top of that, these lenses carry thousands of dollars in out-of-pocket costs per eye, as insurance considers them an elective upgrade. The trade-off is clear: potential freedom from glasses in exchange for significant out-of-pocket expense and a real risk of compromised night vision. The third category offers a balanced middle ground through 2 practical approaches. The first option is extended depth of focus lenses, commonly known as EDOF lenses. Instead of splitting light into distinct separate zones like a multifocal, EDOF technology elongates a single focal point into a continuous range of vision. This delivers crisp distance vision alongside excellent intermediate vision for computer screens and car dashboards, typically producing far fewer nighttime halos than trifocal lenses. The minor compromise is that very fine print may still require light reading glasses, making EDOF lenses a great option for people who want less dependence on glasses without severe night glare. The second balanced strategy doesn't require an expensive premium lens at all. It is known as monovision. In monovision, your surgeon uses standard, affordable monofocal lenses, setting your dominant eye for distance vision and your non-dominant eye for close reading. Your brain naturally blends the two images without you having to think about it. Patients who adapt well enjoy sharp, clear vision across most daily tasks without glasses, all while avoiding the glare of multifocals. The main limitation is that not every brain comfortably tolerates having two eyes set to different focal points, which can occasionally reduce depth perception or cause mild blur while driving at night. The huge advantage, which we will cover shortly, is that you can test drive monovision with contact lenses long before having surgery. One frequently overlooked issue that can ruin an otherwise perfect cataract surgery is astigmatism. Astigmatism occurs when your cornea is shaped more like an oval football than a perfectly round sphere, creating blurriness across all distances. If significant astigmatism isn't corrected during cataract surgery, even the most expensive premium lens will leave you dependent on glasses. The solution is choosing a toric version of your selected lens, which is specially engineered to neutralize that corneal curvature. Failing to address astigmatism is one of the leading reasons patients end up disappointed after technically successful surgeries. Now that we've covered the lens options, let's review what clinical research consistently shows. First, cataract surgery itself is remarkably safe and effective. It is one of the most widely performed operations on the planet, with tens of millions completed each year, and the overwhelming majority of patients achieve fantastic visual improvements regardless of lens type. This video isn't meant to make you fearful of the surgery. The procedure itself is a triumph of modern medicine. This guide exists to help you maximize your personal visual outcome. Second, comparative studies between multifocal and standard monofocal lenses show a very clear pattern. Multifocal patients are significantly more likely to live glasses-free for daily tasks, fulfilling the primary marketing claim. However, those same patients report noticeably more halos, night driving glare, and reduced visual contrast compared to monofocal recipients. This isn't fear-mongering. It is basic optical physics resulting from splitting light across multiple focal zones, confirmed across dozens of clinical trials. Third, research identifies a small subset of patients who experience profound long-term regret after choosing multifocal lenses. While most adapt well, a notable minority suffer from persistent visual disturbances severe enough to require a second surgery, remove and replace the premium lens, an operation that carries much higher surgical complexity than the original cataract procedure. Crucially, many of these dissatisfied patients had pre-existing eye conditions that made them poor candidates for multifocal technology from the start. This brings us to the fourth and most widely ignored research finding. Coexisting eye conditions completely change which lens will perform best in your eyes. Clinical data confirms that patients with specific underlying eye issues rarely do well with multifocal lenses. Conditions like macular degeneration, glaucoma with optic nerve damage, diabetic retinopathy, severe chronic dry eye, or corneal irregularities from previous LASIK already reduce your eye's natural contrast sensitivity. Stacking a light-splitting multifocal lens on top of an already compromised retina only multiplies visual flaws. For these patients, simple monofocal lenses almost always provide cleaner, sharper, and far more dependable vision. Unfortunately, some clinics still promote expensive premium lenses without properly screening for these pre-existing limitations, leading to countless unhappy patients. The fifth encouraging research insight centers on monovision. Your brain's ability to adapt to monovision is highly predictable through a simple trial. Studies confirm that simulating monovision beforehand with temporary contact lenses accurately predicts how well you will tolerate it surgically. Your optometrist fits one contact lens for distance and the other for reading, and you wear them for about 2 weeks in your normal daily life. This allows you to test drive your future vision before committing to an irreversible surgical procedure, a unique advantage that no other lens strategy offers. Here is a practical decision framework that I wish every patient brought into their consultation. Ignore the flashy sales brochures and discard the myth of a single perfect lens. There is no universal best lens. There is only the best lens for your unique eye anatomy and lifestyle. Answer these 5 honest questions to find your ideal match. Question 1. How frequently do you drive after dark? If nighttime driving is an essential part of your routine or work commute, the halos and glare from multifocal lenses can pose real safety concerns and ongoing frustration, making monofocal, EDOF, or monovision options a much safer choice. Question 2. What does your daily close-up visual routine look like? If you spend hours reading fine print, doing detailed needlework, or working closely with your hands and desperately want to avoid reading glasses, the near-vision benefits of a multifocal lens may well be worth accepting some nighttime visual trade-offs. Question 3. Do you have any underlying eye health conditions? Never skip this question. If you have macular changes, glaucoma, diabetic eye disease, chronic dry eye, or prior corneal refractive surgery, approach multifocal lenses with extreme caution and ask your surgeon whether a standard monofocal lens will offer more reliable long-term clarity. Question 4. What is your realistic budget, and how do you feel about wearing glasses? There is zero shame in choosing standard monofocal lenses paired with affordable drugstore reading glasses. Millions of people live active, highly satisfied lives with this setup. Never let anyone make you feel that choosing covered, budget-friendly lenses is an inferior medical choice. Question 5. How adaptable is your visual system, and are you open to a contact lens trial? If you want to minimize glasses use without paying thousands for premium lenses, a simple 2-week monovision contact lens trial can show you whether your brain comfortably blends 2 focal lengths. Now, let me share the insider strategies that separate patients who love their surgical results from those who leave the clinic confused and regretful. Tip 1. Complete a monovision contact lens trial before locking in your surgical plan. If your goal is reducing glasses use, ask your optometrist for trial contact lenses set for monovision and wear them for 2 full weeks. Drive at night, read books, work on screens, and do your normal chores. If your brain adapts comfortably, you have found an affordable, high-quality vision solution. If it causes headaches or blur, you've avoided a permanent mistake for just the minor cost of trial contacts. Tip 2. If both eyes need surgery, consider staging your procedures a few weeks apart. Operating on your first eye and giving it time to heal lets you directly experience your new visual quality before finalizing the lens choice for your second eye, leaving room to adjust your strategy if needed. Tip 3. Demand that your surgeon discuss your specific eye measurements and medical history rather than giving you a generic sales pitch. A thorough consultation must focus on your individual corneal shape, retina health, and daily habits. If the appointment feels like high-pressure sales for a premium lens, pause and consider getting another opinion. Tip 4. Seek a second opinion if your consultation feels rushed or if you feel pressured to commit on the spot. Cataract surgery is rarely an emergency, and an ethical, patient-centered surgeon will always encourage you to take your time and consult another specialist if you feel uncertain. Tip 5. Ask your surgeon the single most revealing question. If you had my exact eye measurements, medical history, and daily lifestyle, which lens would you choose for your own eyes? Their answer, along with how openly they explain the trade-offs, will tell you immediately whether their recommendation is truly tailored to your best interests. Now, let's review the recurring, costly mistakes that I see patients make year after year. Mistake 1. Treating lens selection as a reversible choice. It is not. Many patients casually agree to whatever lens is suggested, assuming they can simply swap it out later if they don't like it. Lens exchange surgery is technically complex and carries real risks, so treat your initial lens decision as permanent. Mistake 2. Choosing premium lenses out of vanity or assuming that a higher price tag automatically means sharper vision. A multifocal lens is not a luxury car upgrade. It is a specialized optical tool with distinct visual compromises. For many eye shapes and lifestyles, standard monofocal lenses provide noticeably cleaner, sharper vision than premium options. Mistake 3. Overlooking pre-existing secondary eye conditions. Agreeing to a light-splitting multifocal lens when you already have macular degeneration or glaucoma can permanently degrade your contrast vision, leading to decades of visual frustration. Mistake 4. Ignoring corneal astigmatism. If your eye has significant astigmatism and you skip a toric correction, your vision will remain blurry across all distances, leaving you dependent on glasses regardless of how much you spent on your lens implant. Mistake 5. Picking an eye surgeon based on flashy marketing ads rather than clinical outcomes and transparent communication. Polished advertising and fancy laser. Branding never guarantee great vision. A surgeon who listens closely and explains every trade-off honestly is far more valuable. Mistake 6. Staying silent during your consultation. The patients who achieve the best outcomes are the ones who ask questions, request clear explanations, and share their daily habits openly. It is your right and responsibility to slow the conversation down until you feel completely confident in your plan. Here's the ultimate takeaway. Cataract surgery is a true modern medical marvel, capable of restoring vibrant, sharp, full-color sight in just minutes. The operation itself is not something to fear, and long-term dissatisfaction almost never comes from surgical error. It almost always comes from an improper lens selection made during a rushed, unprepared consultation. Patients who walk away thrilled are the ones who understood that a major, lifelong choice was in front of them, matched their lens to their eye anatomy and lifestyle, asked thoughtful questions, and refused to be rushed. That small amount of preparation pays off with clear, comfortable vision every single day for the rest of your life. Before your consultation, review those 5 core questions. Know your night driving habits, understand your eye health, and remember that standard monofocal lenses leave countless patients completely satisfied. Let us recap the 8 key takeaways from today's discussion. 1. The defining choice in cataract treatment is the permanent intraocular lens you choose, not the surgery itself. 2. Monofocal lenses provide razor-sharp vision at one fixed distance with minimal side effects and full insurance coverage. 3. Multifocal and trifocal premium lenses offer glasses independence but split light, creating halos, glare, and reduced contrast. 4. EDOF lenses and monovision provide practical, balanced middle grounds with fewer visual side effects. 5. Uncorrected astigmatism causes blur, so always evaluate toric lens correction. 6. Pre-existing conditions like glaucoma or macular disease make multifocal lenses a poor choice. 7. You can safely test monovision with trial contact lenses before committing to surgery. 8. Never rush your decision under sales pressure. Ask your surgeon what they would choose for themselves and get a second opinion if needed. Your vision is far too precious to settle in a rushed 2-minute conversation you weren't prepared for. You have immense control over your final visual outcome, so make your choice armed with complete, clear information. If this video helped you understand your options, please share it with a loved one facing cataract surgery, and subscribe to the channel with a thumbs up so more people can access unbiased medical guidance. Be sure to check out my accompanying videos detailing what cataract surgery feels like and how to select a trustworthy eye surgeon, linked on screen right now.